Hi folks, this is Dr. Rob Cywes. I am the carb addiction doc, and as you can see, I'm not dressed the way I normally am. Still got the little V over here, but we are at the Low Carb USA Boca Conference. It's January of 2024, and I have the pleasure, double pleasure, of being with a colleague and friend of mine, Dr. David Nabert, and he is a cardiologist who specializes in electrophysiology. What does that mean? The way I look at the heart is there's a structural component to the heart, there's some plumbing, which are the blood vessels, which everyone's obsessed about with cholesterol, and then there is the other crucial part, which is the electrical system of the heart. And Dr. Nabert is going to explain that to us, and we're going to ask a lot of questions about that. Arrhythmias, you've heard of atrial fibrillation, a lot of anticoagulation, all these things are going to be explained, and I'm going to learn a lot tonight. Great to see you here.
Hi.
Can you tell us who you are?
Okay, I'm David Nabert. I'm a transplanted Yankee. I started off as an internal medicine doctor, went into the Air Force for a while. That was sort of a previous career. And then I did my training in cardiology in New Orleans at Oxnard. And then I did another fellowship on top of that at University of Louisville on cardiac electrophysiology. And basically, there's two types of heart doctors. There's the plumbers, and then there's the electricians. The plumbers are what you think of most of the time, the people that do the angioplasties, and then there's the electricians who do the ablations for atrial fibrillation, ventricular tachycardia, which are bad heart rhythms, and we also put in pacemakers, defibrillators, biventricular devices. So again, electrician is pretty much the accurate thing.
So let me start because
I'm going to actually interrupt
yes,
you
no,
just for
please,
a second,
go ahead.
Because I wanted to thank you something. I know you are a coffee aficionado.
Oh my goodness.
And a friend of mine who is a locksmith in Mississippi turned me on to this. This has 0 carbs and 0 sweeteners. It's Mississippi mocha. It's as strong as you want it to be.
Wow. That is cool. This is coffee moonshine. Oh, thank you so much.
Speaking of moonshine, I thought we might get a couple of drinks later.
There you go.
Unless you want to start drinking early tonight.
No, that's perfect. Let's do that right. So it's been a long day. I just spoke at this conference. There's my Keton IQ. And so you tell me, just while we're off topic a little bit here, do you notice and what is your indication for using these, and do you notice it and when do you use it? And by the way, folks,
yes,
I didn't give this to him.
He did.
He's giving it to me.
Yeah, and my indication is that after I've been low carb about 2.5 years, and it used to be quite easily my ketones. I use Keto Mojo. I've also used a breath ketone meter as well too. But more recently, my ketones tend to run 0.5 to 1 no matter what I do, unless I'm fasting. I need about 36 hours for the ketones to go above 1.5 to up to 2 range, is about as high as they'll go. And it had some effect on my on hunger. And so you were talking about it, and I was thinking about it. And in the past, I said, I wonder if I can, especially on fast days, if I raise my ketones up a little bit, if that'll make less hunger, and I might just function a little better, because I did feel better with a ketone level of 2 than I did with a ketone level of 0.6. So I do notice a difference, usually on fast days, or if it's going to be a late day where I'm getting home at 8 or 9, and I really wouldn't have had anything to eat until then, if I'm doing OMAD, which is most of the time I will, then I'll definitely have one probably around noon and another one around 4.
Fantastic. And I've had a long day today, so cheers, bottoms up. Always good.
Sorry I did not bring any ice.
No, it goes down the hatch too quickly for me. So I appreciate that. Now that was unexpected, but thank you so much for the moonshine, coffee moonshine.
Well, that's something that I will use that with and without heavy cream.
Yeah, this is just as it comes. We'll try it. So, in terms of the cardiac, the heart,
right?
The way I learned about the heart first, and I think the way everybody and every single person out there has interacted with what you do for a living, if they've had an EKG.
Yes.
So let's start with a simple EKG. And I know this is a very simplistic question, but what is an EKG, and what does it help you to do?
An EKG is a simple electrical measure of the heart's activity. There are things you can get now. One of them is called cardiomobile, which is the simplest type, where you just have one's a positive pole, one's a negative pole, and it measures the difference across your arm. That's the most basic EKG like they had back in Europe well over 100 years ago, and it shows the heart's electrical activity. One way of measuring electrical activity is in the muscle. That's called an electromyogram, but since the heart has a very fast and powerful muscle, we measure both the electricity in the nerves that cause it to beat, as well as measure the muscle. And it will let us know how it fires. It starts off by what's called a P wave, which is when the top chamber of the heart, which are the two atria, which go out of rhythm, are loading the blood into the bottom chambers of the heart. And then the second part, called the QRS, is where the heart will contract, and then afterwards there's something called a T wave where it resets itself, it repolarizes. So it lets us know, is the electrical system working? Are the nerves working properly? Have they been damaged? Or one of the three nerves gone? Is the heart enlarged? Because if it takes too long, you'd say, well, this heart may be 2 or 3 times longer. Is there heart block, meaning the top and the bottom of the heart may not be talking to each other, which is one of the primary indications for a pacemaker?
That's heart block.
Heart block, as opposed to a blockage. People think, oh, I have a blockage. You can have a
That's
blockage.
a plumbing problem.
Yes, a plumbing problem. A blockage in one of the coronary arteries is different than heart block.
That's a failure of passage of the electrical wave.
Yeah, it's where the electrical current is snipped. The wire has been cut.
Okay.
So again, along with I treat heart rhythm issues, primarily at least.
Right.
I do other things as well. But that can cause the bottom of the heart, which is the main pumping chamber, to slow down or stop. If it stops, that's unfortunate. But usually it doesn't. It slows dramatically down to the 20s or 30s where you're about to pass out. You're sort of in a point between life and death. You get to the hospital quickly and put it in a temporary pacemaker, then a permanent one as soon as possible.
But your job is that what an EKG, the picture of an EKG,
right,
is a significant tool that you use every day to look at the electrical system of the heart. Do you think, or what is your recommendation for regular people out there that may not have an EKG? Is it a test that should be done once a year, only when you're sick? What is the indication to get an EKG?
Well, I was in the Air Force, and we did EKGs on everybody coming in at age 18, which gave us a lot of important information about what is normal and what's not normal. Because we see 18-year-old kids that have never had an EKG, and that we follow them for 40 years. So nowadays, generally, there is a recommendation, at least all branches of the military will get a basic baseline EKG. A lot of times you'll get a baseline EKG before any college sports, sometimes high school sports, but usually college sports. So it's good everyone to get one.
And I would recommend that everybody out there, just like you said, irrespective of age, gets a baseline.
Yes.
Because as we talked about earlier on, the EKG changes, or it can pick up certain things in your expert mind or with your expert knowledge of things that I'm not even aware of. For example, we were talking about, especially in the ketogenic space, the diabetic space, QT intervals. Can you explain? I mean, just as an example, I'm not...
Right, okay. I'll use that as a good example because we talked about the first part is it shows the atrium depolarized, the top chamber is firing, then the bottom chamber is firing, and then the heart has to reset itself, and that is the T wave. And if it takes too long for it to reset, parts of the heart may reset first, other parts may reset second, and the two of them are at a little bit of a differential in potential, and it can cause a short circuit. This short circuit, if it starts to re-enter, can cause ventricular tachycardia or ventricular fibrillation, which can kill people.
So the QT interval, that distance, is crucial in terms of if it's long, it can have recircuits, and if it's too short.
There is something called short QT syndrome, which is very rare, and it will also cause a ventricular arrhythmias, where the heart won't repolarize, it won't reset itself.
So it's not pumping adequately.
Yeah, so electrically it won't reset itself, which means mechanically it can't function. So yes.
And we know that there are medications that can prolong QT interval.
Yes.
But tell me about the ketogenic, the diabetes. We were talking about the metabolic. And you and I talked about this a little bit ago. I call it metabolic arrhythmias. So that QT segment, lengthening the QT segment, in your experience, when you look at those, what questions do you ask about somebody's metabolic state?
Well, you mentioned that you said metabolic arrhythmias, and a couple of years ago I thought about that when I started to get involved with this. But I said, well, wait a second, that will make me a metabolic arrhythmia doctor. I don't know if I want to be a mad doctor or not. So I abandoned that for now.
Yeah.
So when it comes to the QT interval, there is some recognition now that diabetes does cause derangement of metabolism within the heart, meaning the mitochondria, the ATP, the channels, the ion channels that make everything work. A lot of times with diabetes, it can be worse, and there can be lengthening of the QT interval, although generally if you're otherwise healthy, a minimal lengthening won't do anything. But if you're on some medicines that will slow down that repolarization, that could set you up for the danger. There are some antiarrhythmic medicines that we watch, they're great drugs like Sotalol or Ticacin, but they will prolong that interval, so that's why we watch people that are on them. There are antifungal drugs, some antipsychotic drugs, or now mental health drugs that we have to be very careful about. And if you add certain types of antibiotics on top of them, things related to erythromycin, frequently to some antifungal drugs, and possibly some other antibiotics, all of them can interact. And if someone that might have a slightly prolonged interval to begin with, and now has these other things, whether it be the diabetes or the drugs, it could put them into a situation where they could potentially have a fatal arrhythmia.
Wow. Fatal, die.
Fatal, die. Yeah, ventricular fibrillation, ventricular tachycardia.
So that's those are subtle things, but it's so important that gets checked out and you've got a baseline. And then you can see over time as you treat your diabetes, as you treat your insulin resistance, that timing might get shorter. And you would know that. People like myself, even a physician, would not know that. Next question along those lines, and this is again how my mind works. A large number of our patients, I would say the majority of our patients, are somewhat obsessed in the ketogenic space. I know I am. Yeah. With electrolytes, sodium chloride, salt, Redmond salt we use a lot of. We use calcium, they use magnesium, they use zinc. And we know, you mentioned earlier on, that the electrical system is actually not electricity as much as it is molecules like calcium and sodium and channels that conduct electricity.
Yes.
How do the electrolytes, too much or too little, because everything's a bell curve, how does that affect the EKG? How does that affect the heart pumping? We know calcium and potassium. Tell me why those are important and why overdosing or underdosing is an issue.
Right. I'll start with potassium, because that's the one that anybody that's on a diuretic worries about. They can have too low an amount. We have very little potassium outside of the cell, a lot of potassium on the inside of the cell, and it's pumped.
Stop. Say that again. That's so important for people to hear.
Right. The potassium, it needs to be on the inside of the cell, and there's very little of it on the outside of the cell. That's where the sodium is.
Right. So 96%, if I remember correctly, of all the potassium in the body is inside of the cells, whereas about 95-96% of the sodium is on the outside of the cells.
Correct.
That's very important because the cells can replenish potassium under the right conditions.
Right. And it's called the sodium potassium pump, and where you get the sodium out, and as the heart fires, as it depolarizes, you've got sodium coming in, potassium going out, and you need the potassium to reset the heart. We were talking about the QT interval, and that if the heart fires and that it can't reset itself, then you're dead.
So those electrolytes are very, very important.
You have to have the right ratio of potassium and sodium. And if you get rid of too much potassium, you can't reset the heart.
So don't diuretics screw that up a little bit?
Yes, they can. Usually your body is pretty good at retaining sodium and potassium, but the loop diuretics like Lasix will frequently cause you to lose too much potassium. But if you have renal insufficiency from your type 2 diabetes.
Kidney damage or kidney problems.
Exactly, and your hypertensive heart disease, then you're going to get rid of less potassium. So you may be able to be on a little bit of Lasix or some hydrochlorothiazide without having to have supplemental potassium. There are some medicines, though, like ACE inhibitors and ARBs, like lisinopril, losartan, that will help raise your potassium. In addition, there's one particular diuretic called spironolactone that we use for heart failure. It's one of the 4 pillars of heart failure.
Potassium-sparing diuretic.
It's potassium-sparing, and it keeps the potassium in. So just because you're on Lasix doesn't mean you absolutely are going to have to be on a supplement of potassium.
But you know how few family doctors who put patients on Lasix or hydrochlorothiazide as a first-line blood pressure medication do not talk about or even think about potassium replacement. I very rarely see that, and sometimes we do have patients with problems with their potassium.
Yes, if they have very good kidneys and they're diuresing quite well, they don't have a high potassium.
But if they're on Lasix, they probably don't have great kidneys to begin with.
Well, that depends. There are a number of people that have pedal edema, and again, from a high carb diet.
That's your leg swelling up.
Absolutely.
And that's usually an indication of heart failure.
It can be, but if you have venous insufficiency where the valves in your legs are starting to leak, and literally the blood pools, and if you're a woman over age 40, you've had a couple of kids, all of that stretches the valves out. So you could have a normal heart, not heart failure, no pulmonary hypertension, which is the lung pressures causing that, and you just have venous insufficiency. Well, yes, sometimes what you can do is actually sclerose the veins off and shunt the blood into the deep veins that are working. But a lot of times we have to figure out, well, is this because you have heart failure, or is this because you have some venous insufficiency and you're on a high carb diet? Now, I used to have
carbohydrates are like a sponge; they suck up water.
I used to have pedal edema, and I would wear support stockings all the time, and then when I went low carb, after a relatively short period of time, within about a month or so, it was like, oh, well, I don't have to wear this every day. I mean, I'll still wear them from time to time for my feet a lot.
And you can actually, under those circumstances, I've had to aggressively de-prescribe diuretics for those patients who came off carbohydrates because they might dehydrate too much.
Yes, absolutely see that. And that's the difficult thing with my heart failure patients, because generally there are not that many heart failure patients that are on low carb diets. Most of mine are not. I give them the
maybe
option.
in your practice. In mine, we try.
Yeah, I give them the options. We do share decision making, but I do have a somewhat heterodox viewpoint on things, and I attempt to not go too far outside the guidelines. And if I do practice medicine within the guidelines, say, hey, this is guidelines. This is why I'm supposed to put you on a statin or a PCSK9 inhibitor. These are options and reasons possibly not to. Same thing with low carb diet and specifically ketogenic diet.
But I like you said it's a shared decision making.
Yes.
And so often I see cardiologists become emotive about you must or you have to. And it's almost a parental approach to healthcare as opposed to a shared responsibility.
Right.
Here's the information, here's the data. Let's make this decision together.
Right.
I love that approach. Let me come back to the electrolytes. Okay. So tell me about calcium, because a lot of people are on calcium. They're worried about calcium levels. What does calcium do to the heart, good and bad? And I'm not talking about plaque. I'm talking about calcium rhythm.
Well, the electrolytes are what are actually working on all of your muscle cells. That goes into the muscle cells, both the heart muscle cells, the smooth muscle cells in your gut, as well as your skeletal muscle too. And that is required for for the muscle cells to contract, the actin and myosin to contract and move past each other, and proper amounts of calcium have to be there. It's on the outside, and it's called the sarcoplasmic reticulum, and then when the muscle fires, the calcium goes in and causes it to contract, and then it gets pumped out, and then this whole thing happens over and over again. If you have low calcium levels in your serum, that means you're going to have low calcium levels in your muscle, and your muscle will not be able to contract and relax properly. And that can cause, again, with the heart, ventricular fibrillation, and that's really the way that you die from very low or extremely high calcium levels.
Right, and a lot of people, the majority of our patients, they're taking vitamin D, they're taking K2. I'm going to come back to that. Well, I'm going to come back to that in a second, but they're worried about their bones.
Yes.
You're not going to die of osteopenia. But if your calcium levels in your blood are affected by that, too high or too low, the thing that it's going to get to you, and most people don't understand this, they don't recognize it, it's going to affect your heart. It's going to affect the contractility of the heart, turn the heart to a stone, which is what I learned when I was a young kid. But here you're hearing it from a electrophysiologist, cardiologist saying, yes, calcium levels affect the heart's pumping ability.
Yes, that's how you'll die.
Wow, that's interesting.
At least it's quick.
Yeah, okay. Well, everything about the heart is pretty quick. So let's come back to because we also hear about vitamin D3 and K2, and in terms of the bones and everything else, what do you know about D3 and K2 in terms of the cardiovascular system or the cardiac system? How does it play? What role does it play in the heart?
Yeah, that is interesting. There are most people confuse vitamin K1, which is the vitamin K that we worry about if people who are on warfarin or Coumadin, and vitamin K2. Vitamin K, for K1, is you can get it from green leafy vegetables. That's why if you're on warfarin, you're not supposed to have them, or just have the same amount every day. Vitamin K2 you get from animal sources, although it's usually made by bacteria. Natto, which is the fermented soybeans that the Japanese use a lot, is a great source of MK7, which is the most active form. And yes, it does have some effect as vitamin K1 as well. But it is also involved with enzymes that help take your calcium and put it into the bones and not into the soft tissue. There is some evidence that it could be involved with reverse calcium transport, which brings up the situation where there are some people and that believe that if you have a lot of vitamin K2, like more than 200 micrograms a day, that you'll be able to suck the calcified plaque out of your arteries. At this point, there's no real evidence. It's questionable even if it could happen, if we would want it to happen, because that could destabilize your nice, stable, calcified, rigid plaques. I don't think that's what happens.
I also am very, knowing the clotting disorder side of things, very skeptical that, but it is promoted because I can understand how you get from A to B around a corner, but I agree with you. That is something we need to be aware of and away from. But overdosing K2...
I think that it can be helpful with bones, though.
Oh, absolutely. Absolutely.
And that is the things that are going to kill you when you're older is loss of muscle mass and fractures. I just had a family friend who had to do her surgical clearance. She was going to have her elective hip replacement at 89. Well, she fell the day before surgery.
Wow. Yeah, that's...
And that totally changes all the risk.
Yeah, no question. But D3 and K2 on the heart specifically?
Well, D3, I do not believe that... I mean, you can get calcification of your vessels with very high vitamin D levels. Mostly it's your soft tissue, not so much your vessels. The soft tissue. You also can get kidney stones. Well, we're talking about vitamin D levels that are very high in the 125, 150 range.
But I'm talking about normal range, because my understanding is that it's also of value in collagen construction.
Yes.
And everything in the body, all the organs are dynamic. They're not just built and they stay there.
Right.
A couple of organs are. But the dynamic nature, the turnover of collagen, especially in the pump, that is the most active organ in the human body. Because it's working all the time.
Right.
Whether you're asleep, whether you passed out, whether you're awake, the heart is working.
Yes.
And it's continuously turning over. And my understanding is that D3 and K2 is of value for that construction and that repair of the collagen structure of the organs.
Yes, for all the organs. There isn't that much that I was able to found on the heart so far. A reasonable amount on the bone because of the protein structure of the bones. We give medicines that are called phosphonates. Off on that, but the whole purpose is that it prevents your bones from being broken down, and instead you just keep putting more and more bone on, which actually isn't the best thing. You want to break down the bad bone, the cracked bone, and build new bone. You just don't want to keep spackling over a wall where it's got cracked bricks in it.
Right.
So anything that might improve the amount of osteoclast, which means the cells that break down the bone, and then a blast which build the bone, so you're building good bone. You're doing true repair. And there is evidence that that's where the combination of vitamin D and K2 help. Also with your immune system as well, too. There was one study done where they looked at a number of variables, people that were hospitalized with COVID. And they looked at vitamin D levels of less than 30 and vitamin D levels of greater than 30. And there was a difference in time and I believe survivability in the people that came in with higher vitamin D levels.
And remember, vitamin D is a steroid hormone, so it's affected by hyperinsulinemia as well. Insulin blocks that. So I got myself off topic a little bit there. Let's return back to, so we talked about the electrolytes, and I think it is so important that we don't overdo them or underdo them, particularly on a ketogenic diet. How does hypertension affect the electrical system of the heart? High blood pressure.
Hypertension, a really good analogy for that is think of a comforter. And you can pull it on the bias, things are okay. If you pull it across, you're going to hear pop, 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 pop. And all the threads that are in the comforter are the nerve cells in your heart. And if you start to stretch out the comforter too much, you're going to pop that. Well, in the heart, if you stretch the heart out to be 1.5, 2 times the size, the nerves don't really want to grow. If anything, they get stretched out and they die. So that's one of the mechanisms that a dilated heart from high blood pressure, because the heart is too much pressure, it's going to stretch out to compensate. The electrical system also gets stretched out and it doesn't pop, it dies. So you develop bundle branch blocks.
So hypertension is closely related to what you do for a living, which is the electrophysiology.
And it also stretches out the valves so that the valves don't close. So now the other chambers get bigger. And you develop heart failure, which means you may a non-ischemic cardiomyopathy, meaning you didn't have a heart attack. But instead, you have now a stretched out boggy heart that we treat with medicines and frequently with a defibrillator because you're at a higher risk of dropping dead suddenly.
So the defibrillator prevents you from having arrhythmias that may cause death. We're going to get to that in a few
treats
minutes.
the arrhythmias.
Yeah. But now, so next question for you in that regard. Let's say I'm 400 pounds, I've got a dilated or hypertrophic cardiomyopathy, and I reverse my weight, I go on a ketogenic diet, and my blood pressure normalizes, even to the point that I can deprescribe medication.
Right.
Does that improve the cardiomyopathy?
Well, the cardiomyopathy normally is going to be improved anytime that you can decrease the fluid volume, or at least the efficacy. It doesn't necessarily increase the ejection fraction, but there's 4 medicines that we use to treat heart failure and cardiomyopathy. There's what are called the ACE-ARBs, which are angiotensin converting enzymes. There's beta blockers. Those are the 2 main ones that help make the heart shrink down some. And there are some other ones that are, I'll call them more or less the diuretics, but that we can talk about afterwards. Some of the beta blockers will lower your blood pressure more. Coreg lowers it the most, while metoprolol lowers it the least. And if I have someone whose blood pressures just can't tolerate it, then I'll put them on metoprolol instead of carvedilol. And there is one medicine called Entresto, which you see.
I was going to ask you about Entresto. I see more and more, it's become a more and more popular drug.
Because it has in some ways hurt my business, because when we just had lisinopril and losartan, about a third of people that had a pump function of 35% or less, with normal being right around 60, if you're at 35 or less,
that's how much blood, the percentage of blood that
about a third of the heart, about a third of the content of the heart is pumped out with each beat, as opposed to 2/3.
Right.
And when you get to 35% or less, for whatever reason, your chances of dying goes up. Your chance of a fatal arrhythmia goes up, which is one of the indications. If we've tried to treat it medically and we can't get the pump function to at least 40%, that's the time when we really start talking seriously about it. We give 3 to 6 months, sometimes longer. But with medicines like Entresto, we found that it works a whole lot better than the regular ACE.
What is Entresto?
It's a combination of an ARB medicine and another medicine.
When you say ARB, what's an ARB?
It's an angiotensin blocking agent. And these work on the kidneys that will help with really direct dilation of the heart. It also will tend to raise your potassium a little bit. And there is another one, a nephrolysin inhibitor, which in itself, we tried those alone. They're not very healthy.
But it's part of Entresto.
But when you mix it together, there's a good synergism where the 2 work together, and it will actually decrease inflammation, and it will encourage the heart to reverse remodel. Instead of being stretched out, it will actually, if you lower the resistance, it'll start to attach itself, so to speak. It'll shrink down.
So it becomes more efficient in terms of its
And when it shrinks down, those stretched out valves that aren't closing properly will frequently start to close better. We get less leakage. So that one medicine has done more to, I'll say, hurt my business than putting in defibrillators, which is wonderful. That's what I want.
Sure.
I've got plenty of business.
No, it's making patients healthier.
It makes people healthier.
So the other, a lot of my patients, when they go and see a cardiologist,
I'm a smart aleck, as you can
but that's great. That's what we. I listen. You got to keep people awake here. One of the things that is a routine test when you go to see a cardiologist. We talked about EKG, but they do something called an echo.
Yes.
And is the echo to look at that aspect that we've just been talking about?
An echocardiogram, the best way I describe it is it's very much like looking at a pregnant woman's baby. We use almost the identical machine, but instead of looking here, we put some gel on the chest and we look up there.